Assalamu alaikum wa rahmatullahi wa barakatuh, guys. Welcome back to the channel of Summary of Standard Medical Textbooks. That is nothing but standard medical notes. So we are meeting after a very long, not long, a short time, because the topic which we will discuss today, which we are discussing today, is a very important topic in respiratory system, and that is respiratory failure. It is a big topic, so maybe we will complete this topic in 3 parts. First part will contain the definition, mechanisms, pathophysiology, clinical features. Second part, investigation. Third part, management. Okay, so let's begin with the name of Allah. So first of all, what is respiratory failure? Failure of pulmonary gas exchange to maintain normal arterial oxygen and carbon dioxide levels is termed as respiratory failure. So our respiratory system is failing to maintain a normal arterial oxygen, which is nothing but PaO2 more than 80 mmHg and PCO2 less than 45 mmHg. So this is the normal arterial carbon dioxide levels. So if the respiratory system fails to maintain this, then that is known as respiratory failure. Coming to the classification based on the types of respiratory failure, type 1 is hypoxemic respiratory failure. So let me zoom this. I think it will not be visible to you. Okay. So type 1 is hypoxemic respiratory failure. That means there is decreased oxygen without elevation of carbon dioxide or decreased carbon dioxide also. Okay, that is hypoxemic respiratory failure. Type 2 is hypercapnic respiratory failure. That is decreased oxygen along with elevation of carbon dioxide. And hypercapnic respiratory failure can be compensated and decompensated. Compensated is usually seen in chronic respiratory diseases, and decompensated is seen when there is an acute exacerbation in patients with chronic respiratory failure. Okay, that is hypercapnic respiratory failure. Type 3 respiratory failure, also known as perioperative respiratory failure, which is seen after general anesthesia. What happens is there is decreased in the functional residual capacity, which leads to collapse of dependent lung alveoli linked to lung atelectasis. What is residual capacity? The volume of air which remains in the lung after maximum forced expiratory volume, forced expiration. The volume which remains in the lungs after maximum forced expiration is residual volume. So maximum how much the capacity which you expire, still there will be some volume of air which will remain in the lungs. That is known as residual capacity. So that will be lost when the patient undergoes general anesthesia. So because that is lost, so alveoli will collapse. So that is known as perioperative respiratory failure. Type 4 is metabolic acidosis. This form most often results from hypoperfusion of respiratory muscles, and good example is in shock patients. So these are 4 types, but most common are hypoxemic respiratory failure and hypercapnic respiratory failure, and both can be acute or chronic. Type 1 hypoxic and type 2 hypercapnic. These are the most commonly respiratory failure which we will deal with, and they can be acute or chronic. Acute is nothing but onset within minutes to hours to days. Chronic is nothing but onset within days to weeks to months. Okay, and one more is acute and chronic. So acute exacerbation, acute flare on chronically stabilized respiratory failure. That is acute and chronic respiratory failure. So coming to the pathophysiology of respiratory failure, so we will divide it as hypoxemic respiratory failure and hypercapnic respiratory failure. So in hypoxemic respiratory failure, diseases which cause this hypoxemic respiratory failure usually impair the ventilation locally with sparing of other regions of the lung. So some part of lung will be involved in the pathology, and the rest other parts of the lung will be normal. So what happens when it is like that? So there will be increased ventilation of neighboring regions of normal lung. That can increase carbon dioxide excretion. So the carbon dioxide which is retained in the abnormal part of the lung will be excreted from the other normal parts of the lung, but cannot augment oxygen uptake, because the hemoglobin which is already 100% saturated, it cannot saturate above 100%. It cannot saturate above 100%. So some amount of hemoglobin will remain desaturated, but carbon dioxide will go away from the other normal parts of the lung. So because of these two phenomena, so carbon dioxide retained is excreted through the other parts of the normal parts of the lung, but the oxygen which is not the hemoglobin which is not oxygenated cannot be compensated by the other parts, because the blood which is flowing is already 100% oxygenated. So hemoglobin cannot be oxygenated above 100%. That's why there is an admixture of blood from the underventilated and normal regions that will cause hypoxia with normocapnia. and sometimes it can cause hypocapnia also. Okay, so that is the mechanism behind hypoxemic respiratory failure. And if it prolongs and involves the adjacent lung units also, then there will be increase in carbon dioxide also, that we will learn in hypercapnic respiratory failure. So remember, any disease which impairs a part of the lung and other surrounding parts are normal will cause hypoxemic respiratory failure. So what are the mechanisms of hypoxemia? Number one and most important mechanism is mismatch of alveolar ventilation and perfusion. Mismatch of alveolar ventilation, I will explain it with diagram, with perfusion. VQ mismatch we call it as. So examples for these diseases are obstructive lung diseases, atelectasis, alveolar collapse, alveolar flooding, mean alveoli are filled with fluid like in pulmonary embolism, bleeding in the alveoli, ARDS. So the alveoli are filled. And in obstructive lung disorders, the pathways are constricted. Okay, so that's how there is mismatch in oxygenation. Okay, I will explain the diagram. Next mechanism is shunting of poorly oxygenated. Shunting is nothing, bypassing of the poorly oxygenated blood. So shunting can be intrapulmonary shunting or it can be intracardiac shunting. In intrapulmonary shunting of poorly oxygenated blood, like example for that is airway obstruction. So because of airway obstruction, that part of the lung will not be oxygenated, and the blood supply to that part will go like that only. That oxygen will not, that part of blood will not be oxygenated. So there is bypassing from that. Major atelectasis, major alveolar collapse or alveolar flooding, again because of filling of the alveoli. Again oxygen, because there is something other than oxygen, there is fluid in the alveoli, so there is no oxygenation of the blood. That's shunting. Intracardiac shunting, poorly oxygenated blood between the pulmonary and systemic circulations cause hypoxemia that responds poorly to the oxygen therapy. Okay, so the deoxygenated blood from the this one cardiac, for example in ventricular septal defect or patent ductus arteriosus or tetralogy of Fallot, so deoxygenated blood will be mixed with the oxygenated blood, and that will cause hypoxia, and that will poorly respond to oxygenated therapy because there is mixing of the blood. Deoxygenated and oxygenated blood are mixed. So the response, as we have learned in the cyanosis part, that in two causes of cyanosis, that is cardiac shunting like VSD and all, these are syndromes, and due to abnormal hemoglobin, there will be no poor response to the oxygen therapy. So number 3 is impaired alveolar capillary diffusion. So the interstitium, when it is fibrosed, so oxygen diffusion will be difficult. So this is seen in interstitial lung disease. Number 4 is low inhaled partial pressure of oxygen. For example, in high altitudes, in the atmosphere only, you will have less oxygen. So that's why there is less oxygenation. Okay, now understand this one. So let us speak what are the consequences of hypoxemia. So consequences of hypoxemia. Now, as we know, basically basics, when you go to the basics, when the aerobic metabolism is impaired, cells will move on to the anaerobic pathway in order to generate energy for the cell. So there will be anaerobic metabolism. That's why there will be like lactic acidosis. Because of that, pH will change, cell will die, and there will be multi-organ failure and death. This is seen in acute cases of hypoxemic respiratory failure. Okay. Second is compensatory physiological response. So there will be transient. This will be transient in chronic cases due to central adaptation. In chronic cases, initially there will be compensatory response, but because the disease is either irreversible or partially reversible, patient will adapt to that. Okay. So what is the initial response? There will be tachycardia, there will be increased PP, and there is hyperventilation. There will be dyspnea initially. Dyspnea. Okay. The dyspnea is the very important initial physiological response, compensatory. Pulmonary hypertension, this can be acute, and right ventricular failure. These two can be acute and chronic also. Okay. Why pulmonary hypertension? Because of less oxygen, there will be reflex vasoconstriction of the pulmonary arterioles, causing increased pulmonary hypertension. Okay. When this is chronic, then there will be remodeling, vascular wall remodeling in the pulmonary vessels. So that will cause chronic pulmonary hypertension. Okay. In right ventricular heart failure, so when there is acute, some like massive pulmonary embolism, there will be acute right ventricular failure. That is understood. But when there is chronic right ventricular, when the disease is chronic, like in a COPD or in pulmonary arterial hypertension, okay, there will be fibrosis of the pulmonary arterioles. So that will cause secondary pulmonary hypertension and right ventricular overload, hypertrophy of the right ventricle due to the pulmonary hypertension, and that will cause cor pulmonale. What is cor pulmonale? Cor pulmonale is nothing but right heart failure due to pathology in the lungs. Right heart failure due to pathology in the lungs is called as pulmonary. It can be acute or chronic. There will be cyanosis also, that can also be acute and chronic. Okay, so these two, pulmonary hypertension, right ventricular failure, can be seen in acute and chronic both. Now coming to two other things, secondary polycythemia and clubbing of digits and hypertrophic osteoarthropathy. These are seen in only chronic respiratory failure. These develop in chronic respiratory failure patients. Secondary polycythemia will be due to, because there is decreased oxygen that will be sensed by the kidneys. Kidneys will secrete increased erythropoietin secretion. So that erythropoietin will stimulate the bone marrow cells, and there will be increased RBCs. So that is the cause of secondary polycythemia, for example in COPD only. Okay, and there will be clubbing of digits and hypertrophic osteoarthropathy. We have learned this topic, okay, in previous classes. So these are the changes which are going to happen when there is hypoxemia. Acutely you can have these four. There is anaerobic metabolism, there is initial dyspnea, they can acute pulmonary hypertension and acute right ventricular failure. Chronically, what you will have? You will have pulmonary hypertension. Okay, you will have right ventricular failure. You will have secondary polycythemia. You will have clubbing of digits and hypertrophic osteoarthropathy. So now I will just explain with the picture by a diagram. So if this is large airway, upper airway, and if this is large airways, and if this is the alveoli, and this is interstitium, and this is the artery. Okay, and this is atmosphere. You think atmosphere. Okay, now when there is decreased atmosphere, oxygen atmosphere, there will be hypoxemia, like in high altitudes. When there is major airway obstruction, again there will be hypoxemia. When there is obstruction in the large airways, like in obstructive lung disease, most commonly COPD and asthma. So again there will be less oxygenation. Now coming to alveoli, when the alveoli are filled with fluid or blood, like in pulmonary edema, either due to volume overload or cardiac failure, or due to some volume overload, or due to nephrogenic pulmonary edema, or it can be due to ARDS, acute respiratory distress syndrome. So oxygen will not enter the alveoli and there will be no gas exchange. So that's how this will cause hypoxemia. Now this is the interstitium. This part is the interstitium. When this is fibrosed, there will be diffusion. There will not be diffusion of oxygen. Okay, so that will cause hypoxemia. So alveoli, flooding of alveoli, like in pulmonary edema due to cardiac or non-cardiac causes. Okay, or ARDS, acute respiratory distress syndrome, and fibrosis in interstitial lung disease, and the fourth is the vascular causes, either to pulmonary hypertension or pulmonary embolism. So the blood will not flow to this artery only. The blood will not flow, or if there is obstruction somewhere in the if you go forwards, if there is obstruction in the artery, then this blood will remain here only and it will not pass to the left ventricle. So that's how there will be hypoxemia. So causes for this is pulmonary embolism. Okay, pulmonary embolism or chronic pulmonary arterial hypertension. These are all causes for this. So this will cause VQ mismatch. This is ventilation and this is perfusion. So sometimes the alveoli will be not normal, but perfusion will be normal. So that but pass will like that only. There will be no oxygenation. Sometimes perfusion will be normal, but alveoli will not be normal. Sometimes alveoli will be normal, but blood perfusion will not be normal. Meaning there will be some abnormal hemoglobin or pulmonary embolism or some obstruction like that. Okay, or if you go forwards, they can be shunting, like deoxygenated blood will mix with oxygenated blood. Okay, this is how you can remember the causes of hypoxemia, and these are the consequences of hypoxemia. Next, coming to the hypercapnic respiratory failure. Understand the. So this is seen in condition that cause generalized severe VQ, ventilation perfusion mismatch, leaving insufficient normal lung to correct carbon dioxide. Okay, that is called as can't breathe. Can't breathe is nothing but I have the capacity to breathe, but I am not able to breathe because sufficient more amount of maximum amount of the lungs is abnormal and minimal is normal. So I can't breathe. That's how what we mean. Can't breathe is just a term to describe, just to remember the causes. Okay, that means maximum amount of the lung is abnormal and minimum amount is normal. So the PaCO2 will increase. Okay, this is one cause. The second cause is any disease that reduces the total ventilation of the lung. How? For example, that will include any generalized diseases like for example upper airway obstruction that affects the ventilation. Ventilation is nothing but cycle of breathing: inspiration, pause, then expiration, inspiration, pause, and expiration. So this is ventilation. So ventilation, what will happen by ventilation? Oxygen will come inside and carbon dioxide will be eliminated from the body. So when there is decrease in the cycle of ventilation due to some cause, so that will cause hypercapnia. So example for generalized lung disease like upper airway obstruction, or most common causes severe COPD, or in some cases severe asthma can also produce hypercapnic respiratory failure. Other causes can be removed as won't breathe. Won't breathe meaning no, lung is normal, but due to some central cause, the medullary and pontines respiratory center are not sending signals to the lung due to some sedation or some drugs or some stroke like that. Okay, stroke which is affecting the respiratory centers. Spinal causes, due to suppose if the thoracic spine is affected, okay, or phrenic nerve which is supplying the diaphragm, that is affected, so that will cause respiratory problems. Neuromuscular mechanism of respiration, for example, myasthenia gravis, Guillain-Barré syndrome, all these will affect the whole lung without any pathology in the lung. Okay, so these are the two main causes of hypercapnic respiratory failure. So what happens? So suppose if initially 25% of the lung was abnormal and 75% was normal, if you don't correct and the disease progresses, this will be reversed. What happens? 75% will behave like abnormal and 25% will behave like normal. So that will cause increased carbon dioxide, because carbon dioxide can't be corrected by only 25% of the lung. Okay, this is the number one cause. Number two cause is due to central or peripheral neuromuscular causes of breathing. Now moving forward. See, mechanism of hypercapnia is mainly alveolar hypoventilation. Remember the word alveolar hypoventilation, meaning there is no movement of the cycle is impaired in the alveoli. Oxygen is not coming, carbon dioxide is not going. So what is the rate or the capacity with which it should come? That is not happening. So alveolar hypoventilation is the most common cause of hypercapnic respiratory failure. So with inadequate ventilation, carbon dioxide accumulates in the lungs. Okay, reducing the pressure gradient across the alveolar capillary membrane. This is the key factor in the development of hypercapnia, because carbon dioxide crosses the alveolar capillary membrane 20 times faster than the oxygen. Okay, so when there is some abnormality, some obstruction like that, so there will be increased partial pressure of oxygen in the alveoli, and blood vessels also there will be increased carbon dioxide. So remember the osmosis. Okay, so concentration is increased here, so there will be less diffusion of carbon dioxide to alveoli, because concentration of carbon dioxide is increased in the alveoli. And in normal condition, carbon dioxide diffuses very faster, 20 times faster than oxygen. Okay, that's why any disease affecting the permeability of this barrier, any disease affecting the permeability of this barrier or reduced lung perfusion will have less effect on carbon dioxide removal than oxygen uptake, because the main thing which will decrease the elimination of carbon dioxide is nothing but the gradient of carbon dioxide between the alveoli and the blood vessels. If that is the concentration difference is less, then that carbon dioxide will not diffuse properly. That is the main cause for hypercapnic respiratory failure. So what is the causes of alveolar hyperventilation? So the causes can be remembered as can't breathe and won't breathe. Can't breathe, the lungs are diseased, and won't breathe, the lungs may be normal, but the nerve supply and the central drive will be reduced. Okay. So coming to can't breathe, first cause, there will be increased load on the respiratory system. Understand this like this: there is a laborer whose capacity to lift a weight is suppose 10 kgs. So he will carry the 10 kg weight on his head, and he will be straight in position. He will stand straight. Okay, you are giving the load according to that. But if you give 20 kg weight, if you give 20 kg weight, what will happen? He will bend, and he may fall also. So because of increased load, he is not doing his function properly. Similarly, when there is increased load on the respiratory system, so there will be alveolar hypoventilation. Okay, so when there is increased load, number one is when there is airway resistance, either due to upper airway obstruction or lower airway obstruction. That is the first cause. Second cause is when there is reduced lung compliance, mean nothing but when the alveoli are stiff, either due to some cause, the alveoli can't expand easily. So the muscles have to apply more pressure in order to expand the alveoli, in order to expand the lung. So that also puts load on the respiratory system. Or third is reduced chest wall compliance. Why chest wall compliance? Chest wall can't expand easily. Why? Because there is some spinal disease or some fluid which is deposited in the pleural space. So that is limiting the expansion of chest wall. Reduce chest wall expanse. Fourth is demand for increased minute ventilation, relative hyperventilation. That means lung is functioning properly, but the demand of the cells is increased for oxygen. That causes relative hyperventilation. Okay, what are the causes for that? Fast will. So in upper airway obstruction, it can be foreign body. Okay, important foreign body in children especially. Laryngeal edema, anaphylaxis, obstructive sleep apnea in obese patients, or loss of consciousness. So the patient will not be able to secure his airway, and the cough reflex will be absent. So in these patients, so causes of lower airway obstruction: COPD, most common, asthma, okay, or bronchial obstruction due to bisecretions like in bronchiectasis or cystic fibrosis, or due to some tumor. Okay, that causes obstruction, and that puts load. Reduced lung compliance due to alveolar flooding. So alveoli are already filled with fluid, so they can't expand. So because of pulmonary edema or bleeding in the alveoli, edema can be cardiogenic or non-cardiogenic or ARDS, or due to fibrosis of the lungs. So fibrosis, because of fibrosis, stiff alveoli can't expand, stiff lungs can't expand. Atelectasis, there will be collapse of alveoli. So again, there will be load on the respiratory system. Next one is reduced chest wall compliance. The causes can be pleural, spinal, or chest wall deformity. So pleural causes can be effusion or pneumothorax. Spinal causes can be kyphoscoliosis. So spine is bended, lateral bending or forward bending of the spine. Scoliosis or kyphoscoliosis, both forward and lateral bending of the spine, will put load on the respiratory system because of impaired alignment. Impaired alignment. And chest wall deformity or some burn on the chest wall. There will be eschar. There will be fibrosis of the chest wall. So the chest wall can't expand. Then demand is increased. Supply is normal, but demand is increased. So that can be seen in shock, sepsis, hypovolemia, or pulmonary embolism. Sepsis, shock, hypovolemia, pulmonary embolism. Hematological causes, you can remember this as. So hematological causes will cause decreased alveolar hypoventilation. Hematological causes. So that is the first cause of alveolar hypoventilation, increased load on the respiratory system. The cause can be airway obstruction, cause can be reduced lung compliance, cause can be reduced chest wall compliance, which includes pleura, spinal, chest wall, and the cause can be demand for increased minute ventilation. Moving forwards, the second most common cause is that is won't breathe. You can remember that as won't breathe. Won't. This is actually won't breathe. Won't breathe actually. Okay. So the causes are CNS causes, central neuromuscular causes, respiratory muscle causes. CNS causes drug overdose like opioids, sedatives, brainstem damage, central sleep apnea, hypothyroidism, severe hypothyroidism, also known as mixed edema coma. Severe hypothyroidism. Okay. Neuromuscular causes can be cervical, thoracic, spinal cord damage, phrenic nerve damage, Guillain-Barré syndrome, amyotrophic lateral sclerosis, nothing but motor neuron disease, also known as motor neuron disease. Okay. Muscle relaxants, myasthenia gravis crisis, tetanus, botulism, all this will impair the transmission of impulses to the respiratory muscles, chest wall. Next is respiratory muscle causes. Most common is electrolyte disturbances like low potassium, hypokalemia, hypomagnesemia, hypophosphatemia or acidosis, malnutrition, hypoxemia itself impair the function of respiratory muscles, shock, muscle diseases. Okay, but the common cause are electrolyte disturbances, okay, malnutrition and shock. So these three are the common causes of respiratory muscle. So these can cause alveolar hypoventilation. Okay, now moving forwards. So these two are the less common causes. Those first two, increased respiratory load, and second one is central can't breathe and won't breathe, are the most common causes of hypercapnic respiratory failure. These two are the less common causes. Increased physiological dead space ventilation. What is physiological dead space? It is a combination of anatomical dead space plus alveolar dead space. Okay, alveolar dead space. So anatomical dead space is nothing but when you breathe, there is, suppose it is 100. So all of the air is not absorbed in the alveoli. Suppose some 50 is absorbed and 50 will not be absorbed. So the 50 which is remaining in the large airways, that is known as anatomical dead space. Alveolar dead space is nothing but when the alveoli are filled with some alveolar flood or due to some obstruction. So these alveoli are not functioning. That is alveolar dead space. Okay. The physiological dead space, anatomic dead space, and alveolar dead space combined Combination of these two are called physiological distress. So example for this is increased alveolar pressure or over distension of alveoli is the volume of inhaled gas that does not take part in gas exchange. Increased production of carbon dioxide to any region in the body will cause alveolar hypoventilation. Okay, so can't breathe and won't breathe are the most common causes. Can't breathe and won't breathe are the most common causes of alveolar hypoventilation, and alveolar hypoventilation is the most common cause of hypercapnic respiratory failure. What are the consequences of hypercapnia? Respiratory acidosis, obviously. This you should remember. There will be headache and altered mental status. Why? Carbon dioxide will cause vasodilation. So there will be cerebral vasodilation and increased intracranial pressure because of vasodilation. That's why the mental state will change. The patient may be drowsy. The patient may be agitated when there is hypercapnia. Okay. So what are the when there is cerebral vasodilation? What are the symptoms? There will be confusion. There will be increased pathologic somnolence. Increased patient will prefer to sleep. Okay, and they can be coma if it is severe also. Then the patient in long term, the patient will develop hypoxic respiratory drive. What is hypoxic respiratory drive? The central centers will adapt to the increased PCO2, will become resistant, or they will become adapt to the increased PSCO2, central centers. So the body will be dependent on the decreased peripheral PO2, which is sensed by the peripheral chemoreceptors, decreased partial pressure of oxygen in order to continue the respiration. So if you acutely increase the respiration in these patients, then the partial pressure of oxygen will increase, and that will give less signals to the chemoreceptors, and chemoreceptors will say to the respiratory center that already there is oxygen. So the respiration which was impaired previously will become worse now. Okay, that's why in chronic respiratory failure patients we don't give much oxygen. We target a oxygen percentage of between 88 to 92%. That is safe oxygen for this. If you go more than 92%, then the respiratory failure become worse. Reason for that is this one. Let us read. Decreased sensitivity of medulla and pons to increased PSO2. In such cases, the main impulses stimulating the respiratory centers originate from PO2 chemoreceptors located mainly in the carotid bodies and the aortic arch. In such patients, too aggressive oxygen therapy and too high PO2 inhibit the respiratory centers and cause hypoventilation, resulting in the worsening of hypercapnic respiratory failure and thus leading to coma. Okay, so these three are the main consequences of, most important consequence is this one, and this is also a consequence of hypercapnia. Okay, chronic respiratory failure, hypoxic respiratory drive, they develop because of carbon dioxide, and chronic respiratory failure patients, same patients will develop pulmonary hypertension, right ventricular failure, and clubbing and hypertrophic osteoarthritis because of hypoxemia, not hypercapnia. Moving forwards, now this is the summary of the causes of hypoxemia and hypercapnia. So hypoxemia with normal or low PCO2, so the pulmonary diseases can be obstructive ventilator disorder like COPD and asthma, mixed ventilator disorders like bronchiectasis. Okay, secretions will block the airway, fibrosis, diffusion will be interstitial lung disease like idiopathic pulmonary fibrosis, pneumoconiosis, sarcoidosis. Okay, allergic alveolitis. So this is most common cause, fibrosis, sarcoidosis also, and vascular disease, pulmonary vascular disease like pulmonary vascular hypertension or acute or chronic pulmonary thrombosis, AV malformations. Okay, this is the pulmonary cause of hypoxemia, causes of chronic hypoxemia. And what are the non-pulmonary causes? Cardiac causes, shunts. So those are severe heart failure that will cause hypoxemia also, and hypoxemia to the respiratory muscles also, and also that will cause pulmonary edema also. Right to left shunt, hepatopulmonary syndrome. What happens hepatopulmonary syndrome? So because of liver cirrhosis, there will be pulmonary effusion. Okay, so pulmonary effusion, so that will cause decreased oxygenation, pulmonary effusion, in some cases pulmonary edema also. So these are the causes of chronic hypoxemia with normal or low CO2. Moving forwards, now hypoxemia with hypercapnia. What are the causes? Pulmonary diseases. You can divide it as pulmonary diseases and non-pulmonary. Pulmonary diseases, obstructive pulmonary disease like COPD, mixed disorder like bronchiectasis or sequelae of tuberculosis, then fibrosis. Okay, so this is can't breathe actually. Can't breathe causes. These are can't breathe causes. Okay, and this is won't breathe causes. Won't breathe. Dysfunction of the respiratory center, for example, central congenital hypoventilation syndrome, obesity induced, depressant drugs, regions of brainstem, neuromuscular diseases. We have discussed myasthenia gravis, AML, poliomyelitis, dystrophies. Okay, chest wall deformities. Chest wall deformities will come under can't breathe only. Okay, chest wall deformities will come under can't breathe only. Remember the causes of hypercapnic respiratory as can't breathe and won't breathe. Here it is given. This is actually from Oxford, pulmonary and non-pulmonary. Remember easily by this. Okay, limitation of chest wall, obstructive sleep apnea. That's all. So now we will move on to one last table because the time is, we will discuss other in the other class. So remember this table. So type 1 is nothing but hypoxic, and type 2 is nothing but hypercapnic respiratory failure. So remember this, in chronic hypercapnic respiratory failure, there will be compensated state. That's why compensation by kidney. That's why there will be increased bicarbonate. So whenever there is increased bicarbonate, then that patient has chronic type hypercapnic respiratory failure. Okay. Coming to acute. So what are the causes of acute respiratory failure? Remember altitude and like that. So acute cause include acute asthma, pulmonary edema due to some cause, pneumonia, collapse, pneumothorax. Okay, pneumothorax, acute cause of respiratory failure, pulmonary embolism, acute respiratory distress syndrome. Okay, now acute hypoxic causes, acute hypercapnic causes. Now when these diseases are significant, or when these progress, if these aren't if these aren't treated, then they will cause this one. So acute severe asthma, acute exacerbation of COPD. So type 2 respiratory failure patient was compensated, there will be acute exacerbation that will become decompensated, and that will cause, no, here it is normal bicarbonate. So it is not chronic type 2 respiratory, it is COPD, just normal COPD, not, it is hypoxemic COPD. So when there is acute exacerbation of COPD, then there will be acute hypercapnic respiratory failure, upper airway obstruction. So these three are nothing but can't breathe. Okay, and these are won't breathe. Acute neuropathy, palsies, narcotic drugs, pulmonary alveolar hypertension, failed chest injury. What is failed chest injury? So the breaking of 4 ribs on both sides. Breaking of 4 ribs on both sides is termed as breaking of minimum 4 ribs on both sides. Both sides meaning the rib is broken at both sides. So that is known as failed chest injury. So that is acute causes. Chronic causes: COPD, fibrosis, right to left shunts, or some carcinoma which is obstructing the lymphatic drainage. So these are the 4 important causes of chronic hypoxemic respiratory failure. And in chronic type 2 hypercapnic respiratory failure, the most common cause is COPD, which is seen. Okay, sleep apnea is also a second point of kyphoscoliosis, myopathies and muscular dystrophy, ankylosing spondylitis. So these are the causes. So in acute, you will see normal pH and bicarbonate. In chronic, also you will see normal pH and bicarbonate. Chronic hypoxemia. In hypoxemia, you will not see any change. When the acute goes to hypercapnic, then the pH of the blood will change, but bicarbonate will remain normal. And if it is decompensated, if it is compensated, then pH will not change, but bicarbonate will increase. But when it is decompensated, pH will also increase and bicarbonate will also increase. So like this also you can remember the causes of respiratory failure. Okay, that's about respiratory failure till now. We will discuss, because it is a lengthy topic, we will discuss further things in the next class. Thank you for your listening, and do comment if any correction is required. Thank you so much.